So I have chosen this very important topic of atrial fibrillation, or I call it as grandfather of all arrhythmias. If somebody asks you which is the most common arrhythmia in the world, or even for the entrance point of view, if somebody asks you what is the most common arrhythmia, then the answer is the premature ventricular complexes or the PVCs. The most common arrhythmia in the day-to-day practice or for the entrance point of view also, the most common arrhythmia is the ventricular premature complexes. If somebody asks you what is the most common sustained arrhythmia in the world, then it is the atrial fibrillation without any doubt. So atrial fibrillation is considered to be one of the most common arrhythmia. And if somebody asks you to speak regarding atrial fibrillation, 60% of your talk will be regarding stroke prevention. Because why we want to know the atrial fibrillation in detail is ultimately we want to prevent the stroke occurring in the patient. Then comes other aspects of management of atrial fibrillation per se. So it is a cardiovascular pandemic with a very complex pathophysiology. It also contributes to significant patient morbidity and mortality. The main emphasis as far as the AF is concerned is the early detection and the stroke prophylaxis. Then comes the disease progression prevention. The significant progress has been made, especially in the management of paroxysmal atrial fibrillation, but we need much better understanding regarding the substrate progression. We will let you know what is substrate and evolution of non-PV triggers and comprehensive approach to multi-system risk factor modification in the AF. So to introduce, as I told you already, it is the most common sustained arrhythmia in the clinical practice and an independent association with cardiovascular morbidity and mortality. And AF is one of the most common cause of the preventable stroke in the world. And the incidence of AF is related. As the age progresses, the incidence increases to 1% in general population compared to as high as 8% in people who are more than 80. The mortality rate compared to general population or compared to the people who are having normal sinus rhythm carries the twice the higher risk of morbidity and mortality. And if you want to classify the atrial fibrillation, the main classification is based on the etiology, and there is classification based on the duration also. So based on the etiology, the atrial fibrillation is classified valvular AF, non-valvular AF, and low. So as the name itself tells, the valvular AF is anything concerned with the cardiac valves, preferably on the left-sided. So anything related to the mitral valve, that is mitral stenosis, and even mitral regurgitation for that matter, or even post-management of these issues like the prosthetic heart valves, and previously done some repair on the valve. So any atrial fibrillation which is associated with any disease or any abnormality of the valves is called as valvular atrial fibrillation. And the non-valvular AF is any atrial fibrillation which is not associated with any valve abnormality, but other cardiac abnormalities, like it may be associated with the coronary heart disease, hypertensive heart disease, heart failure, cardiomyopathy. It can be associated with anything that is called as non-valvular AF. And there is something called as lone AF. Lone means it is lonely, it is not associated with anything. And to call lone AF, the patient's age has to be less than 60. Anything above 60, even without any heart disease, we never call it lone AF. So any patient with less than 60 years without any echocardiographic or clinical evidence of any cardiac or any pulmonary disease is called as lone AF. Why it is important to classify based on this etiology is because first coming to the lone AF, whenever you encounter, you can relax because it is the one type of atrial fibrillation which is associated with least possibility of the thromboembolism. One of the highest risk is the valvular AF, then comes the non-valvular AF. And why there is another reason for the differentiation between valvular AF and non-valvular AF is, and we want to prevent the stroke, there are some drugs which cannot be used in the valvular AF and some drugs which cannot be used in the non-valvular AF. Based on the duration of the atrial fibrillation, it is considered as or classified as paroxysmal AF or persistent or long-standing persistent. So what is paroxysmal AF is any atrial fibrillation which is of less than 7 days duration, or any atrial fibrillation which turns off spontaneously without any intervention, without any pharmacological or any electrical intervention. If the atrial fibrillation is starting off suddenly and stopping suddenly within 7 days of onset, then it is called as paroxysmal. Any atrial fibrillation, if it is persisting for more than 7 days, or any atrial fibrillation which requires cardioversion, then it is called as persistent AF. So it is not only based on the duration, the way you manage it also determines whether it is a paroxysmal AF or a persistent AF. For example, if you are encountering a patient for the first time, suddenly presenting in the atrial fibrillation and in hemodynamical instability, even though it is of 1 hour duration, you may have to give the DC shock to the patient. Then it is called as persistent AF only, even if the atrial fibrillation is less than 7 days, because this atrial fibrillation is requiring cardioversion. So to call it either paroxysmal or persistent, the duration and the need for cardioversion also makes sense. If any atrial fibrillation is persisting for more than 1 year, then it is called as long-standing and persistent atrial fibrillation. If the atrial fibrillation is day-to-day attachment to the patient, or patient has permanently accepted that, or even the doctor has accepted that this patient cannot revert back to sinus rhythm, then it is called as permanent atrial fibrillation. There is a differences in the management of some amount with respect to the duration. We will consider when we discuss the management. So this is the Holter monitoring of my own patient. I think 4 months back, this patient had presented with a sudden onset of stroke in the emergency. A 40-year female patient who was having a non-symptomatic hyperuricemia since the very long time with a depression, was on long-standing antidepressants and the febuxostat, presented suddenly with the left-sided hemiparesis, and MRI showed multiple area infarcts, so which was very much suggestive of embolic phenomena, but we could not identify the source of the embolism in this patient. So we put this patient on Holter to see this. You can see a run of atrial fibrillation in the middle. This was a very important diagnosis. So paroxysmal AF is as significant, even if it is occurring for some minutes, it can pose the risk of having stroke in the patient. And why it is important to classify as paroxysmal atrial fibrillation and persistent atrial fibrillation is very, very important. I think when I was doing MD, I was very fascinated about atrial fibrillation, and I had attended a conference of Indian Association of Electrophysiology in Pune, and one of the guy was giving the talk about atrial fibrillation. And after the talk, I met him and I told him, "How will you define the atrial fibrillation in one sentence?" I wanted his autograph, and he gave an autograph in which he had written that atrial fibrillation is a trigger substrate arrhythmia. So, whenever you speak about the electrophysiology of the atrial fibrillation, it is a trigger substrate arrhythmia. So, what is a trigger? So, any atrial fibrillation usually begins as paroxysmal, and over a time it progresses to become persistent or long-standing persistent atrial fibrillation. So, to begin as a paroxysmal atrial fibrillation, it usually begins as a triggered activity. What is a triggered activity? It means like the premature ventricular complexes, the atrium can also have its own premature atrial complexes. So these premature atrial complexes, which is arising from an ectopic focus, can bang the atrial myocardium suddenly to progressing into atrial myocardium, atrial fibrillation. Then after some time, it spontaneously recovers. Substrate is defined by the area in which this triggered activity occurs, or the atrial myocardium. So the triggered activity is usually premature atrial complexes. The main or the most common site of origin of this triggered activity is the pulmonary ostia, that is the posterior wall of the left atrium in which the pulmonary veins open up. So that is the main area that is called as PV trigger. There are other triggers also based on the other areas, but the most common site of origin of the trigger is the pulmonary vein site. And over a period of time, the recurrent episodes of paroxysmal AF makes the atrial myocardium fibrous. So this causes a fibrosis myocardium of the atria. So then the substrate becomes fibrosed atrial myocardium. So to begin with, it is only a trigger then over a period of time, the substrate in which the triggered activity occurs also modifies, in which the multiple wavefronts starts to occur, where the atrial fibrillation becomes a patient. So, as I told you, the main source of trigger or the driver of the atrial fibrillation triggered activity is usually in and around the pulmonary veins on the left or the posterior wall of the left atrium. There are other triggered sites also, like it can be related to the superior vena cava, it can be related to the there is something called as eustachian area, there is something called as vein of Marshall. These are some identified important triggered sites for the atrial fibrillation, but the most common site is usually pulmonary veins. And even when the electrophysiologists try to ablate the myocardium, it is usually in and around the pulmonary veins. And irrespective of the type of arrhythmia, whether it is paroxysmal, whether it is persistent, whether it is chronic, whether it is long-standing, persistent, or permanent, it poses a considerable risk for the thromboembolism. Even the lower AF also has the risk of having the thromboembolic events, but the cumulative risk is much less compared to other types of arrhythmias. And the main risk of having stroke in the patients of AF, there are other risk factors like more the age, if there's a history of diabetes, if there's a history of previous stroke, if the patient is having the diabetes, hypertension, or congestive cardiac failure, this increases the risk of having strokes. What are the clinical implications of the AF? So why can't the patients have AF and we can just keep quiet? That is because the patient's main issue that we are related is thromboembolism. So compared to the general population or compared to the people having sinus arrhythmia, the risk of having stroke is 4 to 5 times in patients of atrial fibrillation. And even there may not be clinically evident strokes. There can be a microembolia occurring in the patients. So these can increase the risk of dementia in the patients. That the typical name that they have given is dementia cordis, because the embolic site of origin is usually cardia. That's why it's being labeled as dementia cordis. So this can be another entrance question. And overall, the patient of atrial fibrillation have identified to be having a prothrombotic state, because even the risk of the deep vein thrombosis, the peripheral artery disease are also increased in patients with atrial fibrillation. And overall, as I told you, it is a 2 times increased risk for independent CV mortality and morbidity, and even it increases the risk of having sudden cardiac deaths. And it is one of the most common arrhythmia which requires hospitalization. Many of the patients do come with exercise intolerance or also palpitations, giddiness, some pre-syncope. Although pre-syncope is rare, but can occur. And it increases the stay in the hospitals in any patients admitted if the patient has atrial fibrillation. And the overall quality of life is also reduced because of his functional limitations. Patients can have exertional palpitations or dyspnea. There can be an excessive fatigueness. Even though patients have well-controlled ventricular rates, patient can have excessive fatigue and effort intolerance. And there are impaired hemodynamics. Over a period, atria become paralyzed. So, what is the etiology? Why does the atrial fibrillation occurs? Again, it is a multifactorial. It is not the single cause that is doing, like the infection. The bacteria comes into the body, then there is infection. It is not like that. It is a multifactorial. The main important reasons are the advanced age and the hypertension. Hypertension and hypertensive heart disease is the most common cause of non-valvular atrial fibrillation in the entire world. And as we said, any valvular heart disease can have the risk of atrial fibrillation, but the risk is more with the left-sided valve disease compared to the right-sided heart disease. And compared to the pulmonary and the aortic valves, the diseases of mitral valves and the tricuspid valves carries the higher risk. And even the ischemic heart disease or the coronary heart disease is also an independent risk. There are other less important risks like stress, some drugs, even the pulmonary embolism, pericarditis, and hyperthyroidism, some infectious processes involving the myocardium, and some toxins like the alcohol are also responsible for the causation of this atrial fibrillation. So similarly, when we discuss of any risk factors in the cardiovascular section, we usually classify them as the reversible and non-reversible. So if you compare to the non-reversible risk factors first, the age, there are some genotypes who are more prone for atrial fibrillation. If there is a family history of atrial fibrillation and height. So this is not a direct causation, but there have been some studies which are published in Journal of American Medical Association that height is an independent association for the atrial fibrillation and which is directly correlated. There are some irreversible risk factors. The most common are the valvular heart disease, the hypertensive heart disease, and the coronary heart disease. And there are other risk factors like the cardiac surgery. Any it can be a valve repair, it can be coronary bypass graft surgery. So any cardiovascular surgeries can be a risk factor for the causation of arrhythmia. And another recently identified an important and very under-recognized entity is the sleep apnea. So sleep apnea is an independent risk factor for atrial fibrillation. Sleep apnea is an independent risk factor for the hypertension. Sleep apnea is an independent risk factor for the coronary artery disease. Sleep apnea is a direct independent risk factor for causation of the carpal pulmonale. So we are seeing more and more number of patients of sleep apnea coming directly into the carpal pulmonale. That is because we don't have any drugs for sleep apnea. The main type of therapy is usually the CPAP application in the night time. So many of the patients may not accept this kind of management because the understanding of the disease entity and the health education regarding this entity is very, very low. So more and more number of doctors need to emphasize on the importance of sleep apnea being an independent risk factor for cardiovascular health and morbidity. So whenever you see a patient of the atrial fibrillation, you need to evaluate the patient with respect to the detailed history and clinical examination. Obviously, you need a 12-lead electrocardiogram. Only after electrocardiogram, you might have identified this patient as atrial fibrillation. Patient might need transthoracic echo. Some patients of atrial fibrillation may also need transesophageal echo. That is because the main site of the clot formation in the left atrium is the left atrial appendage. So left atrial appendage is not usually visible in the usual transthoracic echo. So we might have to consider doing a transesophageal echo on needed patients. Patients also need evaluation of their thyroid status and the organ dysfunction. And some of the patients, to detect a paroxysmal atrial fibrillation, you might have to put them on Holter monitoring. And to assess their functional limitation, you might have to do the 6-minute walk test. So AF or the atrial fibrillation is a common cause of stroke, and I want to add the terminology called preventable. That is, AF is a common cause of preventable stroke in the elderly. So therefore, it should be recognized because the risk of stroke can be minimalized if the arrhythmia is treated properly. So how will you identify the atrial fibrillation in the ECG? So it is very simple. First and very important is you need to identify an irregular and a disorganized atrial activity, which is usually represented in the ECG as fibrillatory waves. So atria is not at all contracting in the patient. Atria is just fibrillating. So you are not having any contractile activity. Atria is not at all pumping the blood. It is just fibrillating. So this is represented by an irregular disorganized atrial activity. Sometimes these are visible as fibrillary waves. The fibrillary waves can be fine or coarse depending on their morphology. Sometimes coarse P waves can also be mistaken for the normal P waves, but presence of a normal P wave rules out atrial fibrillation. The P wave cannot be normal in atrial fibrillation. Sometimes fibrillatory wave may not be present. Instead, a baseline can be completely flat with just an irregular ventricular activity. The atrial rate is very high in atrial fibrillation. It is usually 350 beats per minute, whereas in atrial flutter, it is usually up to 200. And ventricular rate is irregularly irregular because it depends on the number of atrial impulses which are conducted through the atrioventricular node. For example, if the atria is firing at 350 beats per minute, all the 350 beats cannot be translated into the ventricular through the AV node. So there is some filtering occurring in the AV node. So this filtering occurs irregularly. So that's why the ventricular rate is completely irregularly irregular. And the QRS complexes are narrow because any impulses conducted to the ventricle, it is going through the same normal AV node and the conducting system. That's why the QRS complexes are narrow until and unless the patient has the pre-existing bundle branch blocks or the aberrant conduction pathways. So look at this ECG. This ECG does not have any identifiable normal P waves, whereas this has got multiple P waves which are irregular and which are disorganized. So these are called as fibrillatory waves. And you can see the R wave here. The RR interval is completely irregularly irregular. There is no normal regularity in the R wave. So this ECG in which there is fibrillatory waves along with the irregularly irregular R wave, it is called as atrial fibrillation. Very simple to identify. You cannot miss atrial fibrillation in the ECG. So to go with the detailed ECG features of atrial fibrillation, so these fibrillary waves, as I said earlier, can be present or may not be present. If they are present, it can be either fine atrial fibrillary waves or coarse fibrillary waves. It is very, very difficult to identify fine fibrillary waves. Whereas coarse, if they are present, they are obviously visible. Where amplitude is more than 0.5 millimeter. Some textbooks also mentions coarse fibrillary waves as more than 1 millimeter. But for the practical point of view, if you can see the P waves like this, then it is called as coarse fibrillary waves only. Whereas if there are fine fibrillary waves, it is usually not at all visible. The line will be flat. And if the coarse P waves are very big, sometimes they mimic P waves that may lead to the misdiagnosis. See, the ECG, you see, if you normally it appears to have the P waves, but these P waves are completely irregular. So these are called as coarse fibrillary waves. You can identify the presence of AF by identifying the irregularly irregular QR intro. And if you see ECG, it does not have any identifiable P waves. Instead, the line is flat, except for the lead V1. Sometimes when you want to look at the fibrillary waves, the V1 is the best lead to identify. So this ECG does not have any fibrillary waves. It has got an isolated flat line with an irregularly irregular RR interval. So this is also atrial fibrillation, but without any coarse fibrillary waves. So what happens to ventricular rate in atrial fibrillation? As I said the ventricular response during the atrial fibrillation is irregularly irregular because the rate will depend on the state of the AV node. So normally whatever the impulses are coming from the atria comes to the AV node, stays there for some time, then goes to the bundle branches and the Purkinje fibers. So whenever the AV node activity is heightened by the parasympathetic activity or any AV nodal disease, the ventricular rate may be very slow. Conversely, when the patient have an increased sympathetic activity, the ventricular rate may be very rapid because the activity of AV node reduces here. So, since the ventricular rate in atrial fibrillation is irregularly irregular, whenever you want to calculate the heart rate, so this is a very common practice for the postgraduates in their Viva OC, they will be given the atrial fibrillation ECG. They will be asked to identify and calculate the heart rate in the patient. So whenever you want to calculate the heart rate or the ventricular rate in atrial fibrillation, you need to have a long lead rhythm strip rather than only distance between two QRS complexes like done in normal people. So we usually do the number of big boxes divided by 300 or number of small boxes, the number of RR interval. We usually calculate the heart rate. But in case of atrial fibrillation, you need to have a long rhythm strips. So how to calculate the heart rate or the ventricular rate in atrial fibrillation? So you can identify either the 6-second strips or the 10-second strips. So if you identify the 6-second strips, this can be easily done on the ECG, identify, mark the 6-second group, then count the number of QRS complexes in that 10 seconds. Then you can identify heart rate by calculating it, or you can identify it by making the 10-second mark, or you can identify making the 6-second mark. But 3-second mark is usually avoided. It is minimum 6 seconds or 10 seconds. If the heart rate is very slow, then go for the longer time duration. If the heart rate is a little bit faster, then you can identify based on the 6-second marker. And what you can readily observe is, as the ventricular rate increases in the ECG in the patients of atrial fibrillation. So you can see the atrial fibrillation is 32 in the first ECG, whereas it is 180 in last ECG. So as the ventricular rate increases, the rhythm starts appearing or looking like regular. Although it is not regular, it is completely irregular. But as the ECG starts appearing with a very high heart rate, it starts appearing regular. So this makes the diagnosis sometimes difficult, especially if the patient has the pre-existing tachycardia or the pre-existing supraventricular tachycardia along with the atrial fibrillation, then it becomes very difficult. Sometimes the atrial fibrillation can be mistaken for the SVT. But how we can identify this is by putting the patient on AV nodal blocking drugs. You can do the carotid massage and look for the reduction of the heart rate. Once the heart rate reduces, then look for the RR interval. So if you look at this ECG from the long distance, it appears to have regular complexes. It may appear like a supraventricular tachycardia, like the PSVT, but this is actually an atrial fibrillation. You can identify only after giving the carotid massage or by some AV nodal blocking drugs like the beta blockers or the calcium channel blockers. This usually happens many of the times. The patients get admitted for the palpitations. It appears like the PSVT. Very difficult to identify whether it is AVRT, AVNRT, or AF. But only after giving the carotid massage, diltiazem or metoprolol, the heart rate reduces, then it starts appearing more like an atrial fibrillation. And this is again a differential diagnosis for atrial fibrillation, that is MAT, also called as multifocal atrial tachycardia. Here, it is just a normal atrial arrhythmia in which the atrial premature atrial complexes are arising from multiple sites at different times. So how this is identified? There is usually tachycardia, and the rhythm is also irregular. But each QRS is usually presented by only one P wave, and the morphology of P wave is different. If you check the rhythm strips, there are usually more than 2 to 3 different types of P waves appearing before each and every QRS. So that is how you identify MAT. Because MAT is completely benign entity, it usually occurs in a patient of long-standing pulmonary or pulmonary vascular disease like COPD, pulmonary hypertension, pulmonary, even chronic pulmonary embolism. The MAT is observable, and it is completely benign entity. You need not put the patients on prophylaxis or the rate control drugs, anything. So is atrial fibrillation possible with regular RR interval? Yes, it is possible, but only with 2 conditions. Whenever there is atrial fibrillation with complete AV dissociation. What is AV dissociation? It is called as atrioventricular dissociation. The atria is operating on their own, the ventricle is operating on their own. There is no communication between the atria and ventricle. So that's called as AV dissociation. Or when the patient is having atrial fibrillation with complete heart block or third-degree heart block. So you can see the first and second ECG in which the patients of atrial fibrillation with the complete AV dissociation, in which the QRS is still not wider, in which the rhythm is actually originating from the AV node or the bundle branches. But here, if it's the complete third-degree heart block, in which the QRSs are broader, so the rhythm is originating from the ventricular myocardium, ventricle is operating on their own, and the atria are operating on their own. So this usually occurs when the patient of atrial fibrillation is on digoxin. So digoxin is a one drug which simultaneously increases the automaticity of the myocardium along with the blockage of AV node. So this is the drug which is very much responsible for this third degree block or complete AV dissociation in atrial fibrillation. And many of the patients of atrial fibrillation are usually on digoxin. So whenever the patient of atrial fibrillation suddenly comes with a regularized ventricular rhythm, the etiology is usually digitized toxicity, and they usually present with a complete heart block. And this is another entity where this might be favorite of all MD students. So, as I told you, that the rhythm in atrial fibrillation is usually irregularly irregular. So, there are some long RR interval and there are some short RR intervals. So, sometimes what happens is there is a long RR interval. It is followed by a very short RR interval in which the previous impulse has not passed from the AV node. Suddenly, again, the impulse arises to the AV node, but the AV node is still refractory into conduct. So that's why there appears to be a block. So there appears to be a temporary block, or there appears to be a pseudo block to the AV node, which represents as the aberrant beat or looks like a bundle branch block beat. So this looks like an RBBB if it is a V1. So this looks like an RBBB. So in a patient of atrial fibrillation, a long RR interval followed by a short RR interval in which the beats looks like an aberrant beats. This is called as an Ashman phenomenon, also called as atrial fibrillation with pseudo-ventricular aberrancy. So this does not have any clinical implication, but what it tells us that whatever the aberrancy or whatever the bundle branch block is there, it is not permanent, it is temporary, or it is pseudo bundle branch block. So that is what the Ashman phenomena tells us. Oh, this is one of the very devastating ECG. If you look at this ECG, don't forget to give the DC shot. This is the WPW syndrome with the atrial fibrillation. We know what is WPW syndrome. It is an accessory pathway. There is an accessory pathway from the atrial myocardium to the ventricular myocardium. So what happening in WPW is some impulses are traveling through the atrium and some impulses are traveling through the accessory pathway. But suddenly, what happens if the patient develops atrial fibrillation is more and more impulses start traveling through the accessory pathway compared to the atrial AV node. And in that patient, if you put the patient on AV node blocking drugs, be it a beta blocker, be it an amiodarone, be it a digoxin, be it a calcium channel blockers, this worsens the AV node conduction and again making the tachycardia very rapid and progress directly to the ventricular fibrillation. So this is a direct indication of the cardioversion in the patient. You need to give the DC shock directly if you see WPW syndrome with atrial fibrillation. It might be very difficult to identify the atrial activity in the patients of atrial fibrillation or any patients. If you want to identify the atrial activity per se, there is something called as a Lewis or lead configuration. Again, this can be an entrance question, and this may be important for the postgraduates. So here, what happens is this is a short method to have the ECG. The right arm lead is applied on the manubrium sternum. The left arm lead of the ECG is applied on the fifth intercostal space right to the sternum. Then the left lower leg lead is applied on the costal margin in the mid-clavicular line, and the right lower is usually applied as normally. So this is lead configuration in which we should look at the lead 1 and lead 2 with this configuration. This basically tries to identify the atrial activity in the patient. So Lewis lead configuration is done by and echocardiogram is advised to identify the presence of the valvular heart disease, to assess the atrial size and the ventricular size and what is their functional status, and to document coexisting pulmonary artery hypertension. And there are some predictors in the echocardiography which identifies the patient to have an increased risk of embolic risk. That is, the presence of mitral stenosis of any degree in atrial fibrillation is an independent risk to have a stroke. And the size of left atrium, it is more than 4 centimeter or more than 5 centimeters, then it's very important to put the patient on stroke prophylaxis. And if the patient have reduced systolic function, decreased left atrial appendage emptying velocities, and some types of evidence of spontaneous contrast or thrombus in the LA or the appendage. So, how do you manage the atrial fibrillation? The atrial fibrillation, first thing that you need to identify here is any atrial fibrillation in unstable patient. If the patient is hemodynamically unstable, like the patient coming in acute pulmonary edema, acute shock, the immediate treatment is giving direct cardioversion. So how do you give the cardioversion? Uh, there is some difference between and defibrillation that the students need to identify. The defibrillation is giving the DC shock directly to the chest wall, irrespective of the timing. Whereas cardioversion is giving the DC shock the RR interval. That is the difference between the cardioversion and the defibrillation. So whenever it is possible, always try to give the cardioversion. But when it is not possible, you can identify the R wave, like it happens in ventricular fibrillation or in any systole that you're planning to give the DC shock, then it is usually defibrillation. So cardioversion is giving the DC shock at the height of the R wave. So how do you manage the atrial fibrillation? Whenever somebody asks you what is the management of atrial fibrillation, the first thing and the very important thing is we are trying to minimize the embolism risk here. Next is controlling the rate, and next is trying to get back patients into the sinus rhythm. So first we will discuss the control of the ventricular rate, then we'll discuss about the other things. So as we say, the ventricular response is generally controlled to the drugs that slow down the conduction through the AV node. So these AV node conduction drugs cannot be given if patient has WPW syndrome, because this will increase the conduction through the accessory pathway and will worsen the heart rate. Patients may progress to have a shock or the ventricular fibrillation. So, if you know the rate settings in rate control in the acute setting, then the choice of drug depends on the systolic function. If the patient has normal systolic function, or if the patient is not in heart failure, then it is usually A, B, C, D. That is, A means the amiodarone, the B means beta blockers, the C is calcium channel blockers, and the D is digoxin. And when I say calcium channel blockers, it is the non-dihydrotenin blockers like the verapamil and diltiazem, and it is not the amlodipine or the cilnidipine. It is not the dihydrotenin calcium channel blockers. So only the non-dihydrotenin calcium channel blockers like the verapamil and diltiazem. And if the patient is in heart failure or if the patient has the systolic dysfunction, then you cannot use calcium channel blocker and you cannot use beta blocker in the acute settings because they suppresses the cardiac function or the myocardial function. So the drugs approved are the digoxin and the amiodarone. The beta blockers are usually the first choice of action in an particular function. They have a very rapid onset of action as well as very short half-life in both the oral or IV forms. There are special drugs which are preferred in special diseases like the thyrotoxicosis. If the patient has thyrotoxicosis and atrial fibrillation, it is better to choose the beta blockers, preferably a propranolol. And it is better not to use them in the patients with the heart failure because it will worsen the systolic function, and they are the class 1 recommendation for the rate control. So, the three drugs that we commonly use as far as IV is concerned, usually the metoprolol. What I usually prefer is to give 2.5 to 5 mg IV over 2 minutes, but I will never give it when the patient is in heart failure. You can push the 5 mg IV over 2 minutes, then can put the patient on oral maintenance dose. Similarly, I have given the doses of propranolol and esmolol, which are used much less commonly, and availability is also issue with the propranolol and esmolol. As far as the calcium channel blockers are concerned, both the non-dihydropyridine calcium channel blockers like verapamil and diltiazem are available both in the oral and intravenous forms. They are very rapidly effective and have a short duration of effect. And they have also the very rapid control of ventricular response. And even the oral forms are also available. And my personal favorite is diltiazem. It is available usually in 25 and 50 mg vials. So the dose is 0.25 mg per kg given over 2 minutes. It's very rapidly acting. Keep monitoring blood pressure every 2 minutes when the patient is on duty. The digitalization or the digoxin addition is also very, very important. So this is usually not preferred when the LV function is preserved. The reason is it is not so effective when used alone in a patient to control the ventricular rates. It can be used as a second agent, like with beta blocker. We can use with diltiazem when you are giving the maintenance doses. But and the patient has systolic dysfunction, or you cannot use other drugs, like if the patient is already in shock, patient can have bronchospastic disease due to beta blockers, or the patient has heart failure, it's better to use digoxin. How to give digoxin? If you want to use it in IV settings, then it is given as 0.25 mg IV over 2 minutes every 2 hours with a maximum dose of 1.5 mg. The maintenance dose is usually 0.125 to 0.375. It's given IV or orally. And in non-acute settings, you can use it orally. Like the stat dose 0.5 mg can be given for some initial day, 2 to 4 days. Then the oral maintenance dose of 0.125 to 0.375 dose is given. Digoxin is very slow acting drug, and its maximum effect is not until after 6 hours. So if the patient has pre-existing heart disease, for example, if the patient is recently undergone angioplasty, his ejection fraction is 40%, presented in atrial fibrillation, but patient is not in shock, then it is better to give these patients on digoxin. But keep a check on the heart rate, etc. So digoxin may be very effective in controlling the heart rate at rest. But when the patient exercises, or if the patient is in exertion, or if the patient is in stressful conditions like the febrile illness, the hyperthyroidism, worsening, or some exacerbations of COPD, the rate control becomes difficult when the patient is on digoxin alone. So you need to keep that in mind. So amiodarone, again, it is a class 1 recommendation for the rate control in atrial fibrillation and heart failure, except in coronary artery disease. You cannot use it in coronary artery disease or if the patient having the acute coronary event. But the heart failure, it can be used. It is usually given as 150 mg infusion over 10 minutes, followed by 1 mg per minute for 6 hours and 0.5 mg per minute for 18 hours. This is a very uh, classical dosing of amiodarone that we usually use irrespective of the arrhythmia. Whereas if you want to use it as an oral dose, it is given as 800 mg for the first week in divided doses, then 200 mg OD maintenance dose is maintained. How can you control the ventricular rate in a non-pharmacological way? Used only when the pharmacological agents are not effective or cannot be used, or when there is already an end event called something called as tachycardia-induced cardiomyopathy, in which the intervention procedures like the AV nodal ablation can be done, or the pulmonary vein isolation can be done. But we need to identify that, as I told you, the most common trigger site in atrial fibrillation is pulmonary vein, but it is not the only site. So even if you isolate the pulmonary vein, there are other triggering areas like the, as I told you, insertion of the superior vena cava, the vein of Marshall. Then it becomes very, very difficult to control the rate. Then then the issue comes whether do we need to keep the patient maintained on the sinus rhythm, or we can just control the rate or just prevent the occurrence of stroke, it is sufficient. So this is the ever lasting debate whether rate control or rhythm control is important. So debate was, is there a benefit in reverting back the patient's to sinus rhythm? This particular study called as AFFIRM study, very famous study, and it's been already a decade of AFFIRM study. This study told us that there was no difference in the survival of all the embolic events between the two groups. Even if you don't get the patients to rhythm, sinus rhythm, it is not be much harmful. But more and more studies are coming now. They are telling that even if you can achieve rhythm control, especially in a set of patient, like if the patient is young or if the patient is symptomatic, even if it's rate control, like you can see the AF is controlled rate at 70, 80 heart rate, also coming with exercise intolerance, there is palpitations occurring in between, or the continuous occurrence of stroke is happening in these patients, then you can try to maintain the sinus rhythm in those kind of patients. But it is the dual decision between the patient and the treating physician to revert back to the sinus rhythm or not. But overall, in a patient of long-standing, persistent, or the permanent atrial fibrillation is very, very difficult to get revert to the sinus rhythm. So, if you decide to control rhythm or reverting back to the sinus rhythm, there are three possible ways. One is the spontaneous cardioversion, another one is the pharmacological cardioversion, then there is electrical cardioversion. So, irrespective of the time of the cardioversion you do, whether it occurs spontaneously like the paroxysmal AF, or it occurs with the pharmacological drug or the electrical cardioversion, this conversion carries an independent risk of the thrombus formation and the embolization, uh, especially in the 48 hours duration of AF. And risk is very high immediately post cardioversion. For example, a patient you are presented to the emergency in a shock, you don't know the duration of AF, and you are suddenly given the DC shock. So there might be a cardioversion, that is electrical cardioversion. So this immediate post cardioversion period, the patient is at highest risk for having the stroke. It is very simple to understand also. For example, if the left atrium has the appendage, in the presence of atrial fibrillation, it is not contracting, it is not pushing the drug, pushing the blood into the ventricular. But as soon as it revert back to sinus rhythm, it start to push the blood. So along with the blood, the clots also moves forward, and these atrial thrombi may develop even in patients with negative transesophageal echo. Like even if you are done transesophageal echo, and you have ruled out the presence of atrial thrombi, they can develop even in those kind of patients. So how do you achieve the pharmacological cardioversion? Uh, it is very, actually, practical point of view, it is very difficult to do this pharmacological cardioversion because many of these drugs carry the risk of arrhythmia, and some even carries the risk of the tortuous depointers like class 3 agents. But overall, what is the advantage is they don't require the sedation and it is less frightening for the patients. But they're also less effective compared to the electrical cardioversion. They're usually most effective in less than 7 days. So, atrial fibrillation, more the working capacity of this pharmacological cardioversion. And as I told you, most of these drugs itself are proarrhythmic, and these drugs cannot be given in the day-to-day OPD setting. The patient has to be hospitalized, and before giving these patients on to the patients, patient has to be on the AV nodal blocker drugs. Otherwise, the total deep count. How do you decide the pharmacological cardioversion? If the AF is, I'm sorry, if AF is more than 7 days, if AF is more than 7 days, we usually choose to put the patient on amiodarone or the ibutylyl or dofetilide. If the patient has the paroxysmal AF with a normal LV function, then it is usually class 1 drug or class C. Preferably amiodarone. So you can see amiodarone works in all three formats in controlling the rhythms. So amiodarone is one drug which is helpful for both the rate control and the rhythm control. This is again a multiple times asked entrance question, that which one of these drugs controls both rate and reverts back to the normal rhythm. Then it is amiodarone, and amiodarone is working in all duration of atrial fibrillation, irrespective of the LV function, except in coronary heart disease. So only one area where you don't put the patient on amiodarone is the ongoing ischemic activity in the myocardium. And electrical cardioversion, I don't know how many of you have given electrical cardioversion. This is just a direct uh, current given to the chest wall, performed under the IV sedation. And if the duration of the AF is more than 48 hours, the cardioversion should never be done with 3 weeks anticoagulation prior to the cardioversion. So if the AF duration is more than 2 days, put the patient on anticoagulation for 3 weeks, then give the DC shock, then you have to maintain this anticoagulation for the 4 weeks. So it is 3 weeks anticoagulation, electrical cardioversion, then 4 weeks contact anticoagulation. That is the rule. If the AF duration is less than 48 hours, then you can conduct the transesophageal echo. If there is no thrombi, then you can give the cardioversion. So, as if the need is very urgent, we can do the transesophageal echo. So, but as I told you, even in the negative transesophageal echo, also, if you do the cardioversion, the risk of stroke increases. And what is the most effective way of reverting back to sinus rhythm? If somebody asks you, then it is the cardioversion. It is not the pharmacological cardioversion. And before electrical cardioversion, again, the patient has to be on the antiarrhythmic drugs. Next, coming to the most important aspect of the atrial fibrillation, that is the thromboembolic risk management. So, current recommendation is to use an anticoagulant therapy in all patients with AF, except those with a low atrial fibrillation or with a contraindication to antithrombotic agents. There are three diseases which are with highest risk of having embolic disease. One is mitral stenosis, another one is the patient of hypertrophic cardiomyopathy, and the patient of previous stroke. If the patient has three risks, like if the patient has mitral stenosis, hypertrophic cardiomyopathy, and previous history of stroke, the patient, without any second doubt, should be put on anticoagulation therapy. So, if the patient does not have these three, like if the patient does not have any mitral valve disease, if the patient does not have hypertrophic cardiomyopathy, if the patient does not have previous stroke, then the patient is assessed based on the risks. So this risk assessment scoring is called as CHARTS 2 VAS score, where you might have already heard this. So this assesses the patient based on the presence of congestive heart failure, hypertension, age, diabetes, previous embolic events, vascular disease, the age, and again the female category. So according to the percentage of having the stroke, the annual CVA risk is similar to the score. So the score 1 carries risk of 1.3%, score 2 carries 2.2%, 3 carries 3.2%, and 4 carries 4%. So the rule is, if the patient is having atrial fibrillation with a mitral stenosis, hypertrophic cardiomyopathy, and previous history of stroke, irrespective of the CHARTS 2 VAS, you are putting them in anticoagulation. If the patient does not have these three entities, then calculate the CHARTS 2 VAS score. Then what the textbooks used to say is, if the CHARTS 2 VAS score is more than 3 in males or more than 2 in females, they have to be kept on the anticoagulation. But now the risk category is reduced. It is score of 1 and 2, that is 1 in female and 2 in males. The patient has to be put on anticoagulation. And when you put the patient on anticoagulation, you need to also assess the risk of bleeding in this patient, because these increase the risk of bleeding. So the risk of bleeding is assessed by this score called Hasbled score. Again, this is a very famous YOC question. Uh, if the risk is more than 2 or 3, we usually don't put the patient on the anticoagulation. So number of trials have attempted to compare the benefit of the antiplatelets versus the anticoagulation in minimizing the risk. But overall, the warfarin, that is the anticoagulation, shows the maximum risk reduction in atrial fibrillation compared to the aspirin. And even head-to-head comparison of aspirin and clopidogrel, they are similar. But compared to the single antiplatelet drug, the dual antiplatelet drug is superior, and it is inferior to warfarin therapy. So best is anticoagulation. If it is not possible, then put the patient on dual antiplatelets. If it is not possible, then the patient is chosen for the single antiplatelet. But patient for the stroke prevention, if you are putting only on aspirin, then you are creating the blunder. So what drugs we usually put them on is, as if we decide to put the patient on on anticoagulation, then we want to know whether it is a valvular atrial fibrillation or non-valvular atrial fibrillation. In the valvular atrial fibrillation, only warfarin is indicated. We cannot use the newer oral anticoagulants in valvular atrial fibrillation. So these newer oral anticoagulants are approved only for non-valvular atrial fibrillation stroke prevention. So there are 4 drugs available. One is direct thrombin inhibitor, that is a dabigatran. Other are factor 10 inhibitors, that is rivaroxaban, apixaban, and edoxaban. So they have got initially they were trying to prove the non-inferiority compared to the warfarin, but over a period of time in their evidence has shown that they are not only non-inferior, but they are superior compared to the warfarin. The advantage being warfarin is a one crappy drug. When you put the patient on warfarin, you need to maintain the patient of INR between 2 to 3. Otherwise, it is not useful. And it is very difficult to maintain this INR between 2 to 3 because dose adjustment varies very rapidly. It is related with the food intake, it is related with the gut microbiota, it is related with the drug interactions. So it is very difficult to modify the dose of warfarin, and sometimes patient ends up in bleeding with lost in the follow-up. So that's why we wanted a drug which is equivalent to the warfarin but does not require any monitoring. So that's why it brought up to identification of newer oral anticoagulants. These are very commonly used nowadays. So like 20 to 30% of my prescriptions are with the newer anticoagulants nowadays. So the most commonly used by personal favorite is usually apixaban, but it is depends on the ability and the cost to the patients. And if the patient is already on warfarin, it is well maintained, then you can continue the patient to be on warfarin. Don't try to change if the patient is well maintained. Try only if it is not working or it is not possible to maintain the INR. And other drugs like the ACE inhibitors and ARBs are can be used because they have tried to show to reduce the LA pressure by reducing the frequency of premature beats. So they can be used as a disease modifying agents, just like the way used in heart failure. Again, statins, it is similar with their pleiotropic effects of anti-inflammatory and antioxidants, but they do decrease the risk of AF recurrence. Whenever the patient you want to put them on anticoagulation, if it is not possible, then you can put the patient on something called as Watchman device or the left atrial appendage closure devices, in which it puts a closure device at the entrance of the left atrial appendage where so that no blood enters into the left atrial appendage and no clot formation occurs. So these can be tried the patients in which the sinus rhythm is not possible if the patient cannot be put on oral anticoagulants. So I have discussed with the possibility of the pharmacological cardioversion. It is very less used, although I have given it in the PPT, you can study on your own. This newer entity is something called as pill in the pocket approach, in which the intermittent antiarrhythmic drug therapy can be advised to the patients, in which the symptoms are very infrequent. They are so infrequent that you cannot put the patient on regular drugs, but they are long lasting enough to disturb the patient's activity. So in that time, you can use the patient something called a spin the pocket approach. So you can put the patient on the alternative or compared to the daily and alternative day anti-arrhythmic therapy. This on need basis anti-arrhythmic therapy can be given. The drugs which are approved for this pill in the pocket are only two: this flecainide and tropophenone, that is class 1C drugs. So often prescribed with a short-acting beta blocker at the same time. So the patient first have to take the metoprolol 50 mg. Then after 10 to 15 minutes, they have to take a single dose of either flecainide or tropophenone, depending on your choice. So if you see some considerations, the post-operative AF, the incidence is 20 to 30%, very commonly seen in medical colleges. It is usually self-limiting. You need not put the patient on cardioversion. The two drugs which are shown effective, one is ibutilide and sotalol. Ibutilide is one drug which needs a very prudent monitoring. You have to be there on the bedside. And again, sotalol is a class C drug. You can put the patient on class C drugs. And again, the most important post-operative AF that you are worried is post-CABG patients, in which the risk of stroke is very high. You need to put the patient on heparin, followed by oral anticoagulation if the AF persists for longer than 48 hours. And if the patient of acute MI develops AF, then it is a very devastating event. It is usually associated with older patients, higher clinic class like 3, 4, and previous dysfunction, or if the patient has triple vessel disease, preferably. And it carries a worse outcome of 30 days mortality. The urgent direct cardioversion is advised in patients with acute MI with hemodynamic instability in which the AF is there. And IV beta blockers can be recommended based on the ejection fraction or based on the presence of pulmonary edema. The anticoagulation in large arterial wall MI and in persistent AF is must because there is a risk of both atrial thrombi and the ventricular thrombus formation. And again, you need to put the patient on long-standing ACE inhibitors and as far as the pregnancy is concerned, it is not so common, but it is identifiable in patients with mitral valve disease. If there is hypothyroidism and if there is a pulmonary disease, you can use beta blockers without any problem. You can use even the diltiazem and the digoxin. They are not at all issue with the pregnancy, but you cannot use other anti-arrhythmic agents. But amiodarone you can use, but you need to monitor the patients for thyroid status. But what is important here is direct cardioversion is not a contraindication in pregnancy. So even if the patient of pregnancy comes with the hemodynamic instability, the main treatment is cardioversion. It is not at all concerning with the fetal damage. And as I said, AF in hypertrophic cardiomyopathy is the highest risk compared to the similar to the mitral stenosis. So anticoagulation is must, and the anticoagulation is usually warfarin, not the newer oral anticoagulants. And recently, we have got the Samsung and Apple watches in which they are told to identify some other abnormalities. So they usually identify the atrial fibrillation only. They cannot identify the myocardial infarction, but they can identify the abnormalities. Although there is some false positives like a simple ectopic occurring are detected as atrial fibrillation, but many of the patients of mine have turned to the hospital that their ECG in the Apple Watch is showing atrial fibrillation. So in those patients, even when you see they may not have atrial fibrillation, they can have paroxysmal atrial fibrillation. So whenever the watches detect atrial fibrillation, it can be there or it may not be there, but try to put the patient on Holter monitoring and to see the possibility of paroxysmal atrial fibrillation. And this was a statement by Dr. Venkatesan in 2016, which is still true. So many of the people don't try to put the patient on digoxin. The digoxin is one wonder drug in atrial fibrillation. So medicine need not be practiced not only with the best science, but also in a holistic and cost-efficient manner. There is no place for glamour, glitter, and commerce in prescriptions. In near future, teaching medicine to students would essentially become more of moral than a science. So because nowadays, even though we are in a period of uh, all gospel are not published, and all published data is not gospel truth. That is what I want to try to confirm us saying here. So if there are any doubts, you can take here, or you can